Thank you for that very nice introduction. The one thing that Melissa left out is that I also have the privilege of working with her every day, and that actually is more important than a lot of those other things she just mentioned. We have a great set of advanced practitioners at our institute. So I'm going to speak to you today for the next half hour or so on the topic of cord blood and haploidentical stem cell transplantation, and what are some new things going on in those two fields. So why do we even talk about these issues? Well, family sizes are getting smaller, and we know that the likelihood of finding a donor is directly related to the number of siblings that one has. The other issue is that the population that we're transplanting is getting older, and so older siblings who are less optimal might not be around to actually be donors. And then if we go to the unrelated donor registries, we know that individuals who are of non-Caucasian or Western European origin really have low rates of finding perfectly matched donors for transplantation. And this is a graph that was published just last year that shows over time the likelihood of finding a donor for a number of ethnic groups. Now, you don't need to see everything to understand that the group up here are white Europeans in origin, and all other humans, if you will, have rates of finding donors in the rates of 30 to 50%. And that's just insufficient for the population that we need to transplant. So we need to use alternative donors. And the two sources out there are umbilical cord blood and haploidentical siblings or parents, or children, actually. So for those of you who have seen this talk before, I've actually gone and sometimes spent 45 minutes really just contrasting and comparing the differences between these two sources and giving you my personal opinion as to which one of these two sources is better for all of these reasons. But instead of going through that 45 minutes, I'm just going to summarize it right here. So, in my opinion, cord wins in certain aspects and haploidentical transplantation wins in others. So it's much easier to identify a cord blood unit and to obtain it. No one has to go to the operating room. So the shipping and calling FedEx saves me a lot of pain in my shoulder rather than going to the operating room and getting bone marrow from a donor. So cord wins on the first two sides. From an engraftment point of view, haploidentical bone marrow or peripheral blood engrafts relatively quickly, so that is a winner for haplos. Graft versus host disease, in my opinion, is much less severe and less prevalent after cord, so there's a notch on the cord side. But treatment-related mortality is very high after cord, so haplo wins there. There is some evidence that double cords do very well in terms of anti-leukemic activity, and the unfortunate evidence from the haplo side is that relapses appear to be high. The problem with cord is that we have no access to cellular therapy products. So if one wants to do DLI or do something fancy and manipulate things, there just is no more product to work with. So haplo wins both from a cellular therapy and an immunologic reconstitution point of view. And then survival I've put right out in the middle because I don't actually think that we know just quite yet at the end of the day which is better. So that's a summary of the main differences. And people have tried to compare them using prospective and retrospective studies. And so this was just published a few weeks ago in Cancer and compared things like engraftment. So the curves on the left show the rates of neutrophil and platelet engraftment, and haploidentical transplantation always wins. It comes up quicker, and there's a higher incidence of engraftment. From a platelet point of view, the results are even more striking. And then on the right side of the graph is resource utilization. How many units of blood? How many units of platelets? How many days is the patient actually in the hospital? And haploidentical wins generally in this sphere as well. But these are retrospective comparisons. And so the first real attempt to compare these two, and no talk on cord and blood transplant is really complete without at least an overview of CTN 0603 and 0604. So this was a prospective attempt to compare cord blood and haploidentical transplantation. They were two parallel phase 2 trials that were done at about 16 centers nationwide. It was not one study comparing or randomizing cord versus haplo. Each center had to decide which trial they wanted to participate in, and all you got to do was either cords or haplos. And this was published a couple years ago already. I'm just going to skip the patient characteristics, other than to say 50 in each arm, roughly distributed evenly. And here are the two regimens that were used in these studies. So haploidentical is on the bottom, cord blood is on the top, and the regimens we used in the trial were from the centers that really were pioneers in those techniques. So Minnesota, one of the leaders in cord blood transplantation, their regimen was fludarabine, cyclophosphamide, and a single dose of TBI, followed by double cord stem cells, and then cyclosporin MMF as GVHD prophylaxis. This is a reduced toxicity or reduced intensity transplant. And the Hopkins protocol for haploidentical transplant is on the bottom. This was, again, fludarabine cyclophosphamide, 1 dose of TBI, and then post-transplant, very important, as you just heard, the post-transplant dose of cyclophosphamide, 50 milligrams per kilogram. And you'll notice that's much bigger of a dose than the dose we gave as the preparative regimen. The patients also got some MMF and tacrolimus. And so the curves I'm going to show you are not superimposed on purpose. Again, we are not allowed to formally compare one or the other. But what we see for in neutrophil engraftment, the haplo curve is a little bit steeper, so the median was a little bit shorter. Again, no p-values because there's no formal comparison. You can make comparisons in your own mind if you'd like. From a platelet point of view, cord is on the left, haplo's on the right. Clearly, it looks to me that the platelet engraftment was much more rapid with haplo, and it hit a much higher plateau, so 95+% of people engrafted platelets, whereas in the cords, plateaued here around 80%, and it took a long time to get there. For acute graft versus host disease, the upper curves are grade 2 to 4, the lower grade 3 to 4. No real difference, 32-40%. That's probably the same statistically if one were actually to compare them. But one would note that in the haplo arm, there was no severe graft versus host disease, no 3 or 4. From a chronic GVHD point of view, this is what we all strive for, these very low rates of chronic GVHD, 15 to 25%. Those are really great and probably comparable, although one would say that this perhaps is a little bit better. And this is short follow-up. This is just 1 year. From a relapse and non-relapse mortality point of view, what one sees is that the curves are very splayed here in haplo. So 45% of the patients on the haplo arm relapsed. And one could go so far as to say that if you're going to have half of your patients relapse after transplant, this might not be something you want to pursue at all. Relapse rates in the cords were lower, but there was non-relapse mortality. 1 in 4 patients died of a non-relapse cause in the cord arm, whereas very few patients died in the haplo arm of non-relapse mortality. And then finally, disease-free and overall survival. These curves are probably superimposable if one were to do that, and this is why when I showed you those outcomes and differences slide, I put survival smack dab in the middle. They both have their advantages, they both have their disadvantages, not entirely clear which is going to win. And here's our attempt to find out which one is truly better. So this is CTN 1101. This is a randomized trial. This is a formal comparison. It is essentially 0603 versus 0604. To get on this trial, however, you must have both types of donors available. So you can't just hope that you're going to get randomized to the haplo arm because you've got a good haplo SIB floating around. You actually have to do a formal cord search and identify cords, and you have to type your siblings, parents, or children and identify the haplo donor, and then one gets randomized to the 2 stem cell sources. And we're going to try to put 400 patients on this trial. We've got about 150 patients or so. So if you see people in the clinic, if you're doing intake, this is the type of thing that you want to mention to them on an early visit so that the concept of this randomized choice between cord blood and haploidentical transplant is in the patient's mind early, because we need all the help we can get to accrue to this trial. We're going to look at 2-year relapse-free survival, and it is powered with 400 patients to detect a very small difference. So 15%, a lot of people would not consider very important, but with 400 patients, one could actually, from a statistical point of view, be very precise and detect small differences. Okay, so that's a review of what's actually out there. I'm going to move to what's actually new and what the future holds for cord and haploidentical transplantation. And the problem with what I'm going to tell you is that everything that seems new and cool in the next 20 slides has already eclipsed what we're doing in 1101. Okay, so there are tons of different technologies and other strategies out there, and if some of these seem better than garden variety cord blood transplantation, the concern is that by the time we get the results of CTN 1101, are we actually going to care about them or even believe them? And that's a big problem in the field, and that's why we have to finish this trial quick. So when we talk about transplant, it is really this big black box. We don't really know what we're doing. We give some chemotherapy, we throw some radiation at the patient, we just squirt some stem cells, or what we think are stem cells, into a Hickman catheter, and then we hope that 14 to 21 to 30 days later, we get some neutrophils back, the patients develop an immune system, and they get to go home. But there's a ton of stuff that goes on in the middle, right? So these stem cells that we give have to find their way to the bone marrow, they have to expand, they have to differentiate into all the various hematopoietic lineages, and they have to develop diversity. They have to learn how to react to this new world, right? So you're giving people stem cells. They have no memory for the common cold or measles or anything. So they have to learn to develop this immunologic diversity. And it's all of this that people are trying to work on in terms of ways to improve cord blood in particular, as well as in haploidentical transplant. So homing is a very complicated process that we don't really understand, but there are lots of steps involved. So this stem cell that's floating around, under the influence of these chemokines and the chemokine receptors, has to find its way to the endothelium in the bone marrow. It's got to stick and roll along that endothelium, find its way through, and then into this little niche that we think it likes to live in within the bone marrow space. And there are a number of chemicals and chemokines that we know are attractants for the stem cell to find its way home. And some of the big ones are things like SDF1 and CYP1, and in the interactions with the CXCR4 receptor. And we've taken advantage of these to try to find better ways of getting these stem cells into the bone marrow. So we can upregulate the receptor for the endothelium and the bone marrow niche on the stem cell, this CXCR4 chemokine. We can increase the concentration of the chemoattractant hormone within the bone marrow, SDF1. We can make the niche a little more hospitable by building the bone sinusoids up with drugs like parathyroid hormone, or we can modulate CYP1, which might be the strongest chemoattractant that we currently have no tools for right now. If we can not find a way to make these stem cells find their way home better, perhaps if we just make more of them, then we'll get more of them to find their way home. And so some of the biggest things in cord blood right now are expansion technologies of trying to simply make more stem cells. There are multiple different companies and techniques and technologies out there for people that are trying to perform this cord blood expansion. And there are two broad approaches. Either you can sort of take these stem cells and try to put them into a scenario or an environment that seems like the bone marrow and make them expand in flasks or culture, or you can do something chemically to them and manipulate them and sort of turn their signaling on to make them expand. And here are the four leading technologies that are out there. So Colleen Delaney from the Fred Hutch has pioneered a technology of Notch expansion, and Notch is an important signaling compound. The group at Minnesota with Novartis is working on stem Regenin-1, which is an exogenous chemical that makes stem cells go crazy and grow. The Israeli company GamedaCell is working on something called nicotinamide, which is basically a vitamin, and somehow this makes the stem cells grow in culture technique. And then there is a group that's working on this mesoblast technology where they grow the cells in direct contact with mesenchymal stem cells, and somehow that induces the hematopoietic stem cell to grow. So very quickly, the Notch-Mediated Expansion, you take this chemical, the delta-1 part of the notch, which has we know the receptor is found on hematopoietic stem cells. You take these cord blood progenitors, you put them in a flask, you expose them to this compound for 2.5 weeks or so, and then you can harvest the cells and transplant them. And what we see with the notch stem cells is that you can make huge numbers of stem cells, and you can actually reduce the time to engraftment. The problem that's shown in this set of graphics, so 8 individual patients, you have the white count, which is shown in the line, and then you have the percentage of the notch expanded unit in the shaded bars. So looking at, let's say, this patient first, you see that very early on, the notch expanded unit, the shaded bar, is relatively high for the first 10, 15 days, and the white count climbs nicely. So patients are engrafting quickly, but look what happens over time. The proportion of hematopoiesis contributed by the notch expanded unit goes down, and goes away. And so this notch manipulation is not just expanding the units, but it's doing something to them to make them lose their stemness. They just can't keep regrowing and regenerating themselves. And so this has a role, perhaps, to mitigate the time of neutropenia, but it's not going to be the answer in terms of long-term hematopoiesis. There is this nicotinamide-mediated expansion, and this is an example from one patient performed on this trial that looks, a number of patients performed on this trial. Those patients get one unit that's expanded with nicotinamide and one unit that is not. And the patients who engraft with the nicotinamide unit have white counts that skyrocket and are almost in the normal range by 10 to 15 days. But if you look at the patients who are engrafting with the non-nicotinamide unit, their time to engraftment is way out there, 24, 28 days. And so this appears to be a promising set of technologies as well. And this is a clinical trial that's being done at about 15 centers in the United States. There's one technology called the MSC stromal cell expansion. This is pioneered by the group at MD Anderson and now taken over by the Mesoblast company. So they take these Mesoblast multipotent progenitor cells, they grow them up in these flasks, you throw your cord blood unit in them, and then you've got to culture it and reculture it, and it's very labor intensive. So this is actually not done at your own center when your patients are on this trial. You have to send the cord blood units to these for-profit culture companies, basically. And they do this for you, and then they ship the unit back. And a lot of us have a lot of trouble sort of relinquishing that unit and sending it out and sort of not being too comfortable with the fact that you just don't know what's going on. But it turns out that when the cells come back, they work, they engraft relatively quickly, and in fact, there was a paper in the New England Journal of Medicine last year on some preliminary results, and this seems promising as well. The most promising might be this SR1 technology that is being pioneered by John Wagner at Minnesota with the Novartis group. There's other things coming down the pike. These I don't know anything about yet. They're not actually in clinical trials, but in preclinical models, some of these might even be better than SR1. So what did we do at our center? We focused on this prostaglandin compound because in mouse and in vitro studies, it looks like this compound, when stem cells are exposed to it, changes multiple properties of the cord blood. It helps them home, it helps them expand, they differentiate better, and they generate better immunologic diversity. A lot of those negatives on that comparison slide I showed you. So our last trial, we treated 12 individuals, and the rate of engraftment was 100%, so there was no graft failure. This curve goes right up to 100%. When we compare to a group of 50 prior cord transplants done at our institution, we got the cords to come in a little bit quicker, and again, not everyone engrafted in the past, now they're all engrafting. And then this curve down here demonstrates exactly the opposite effect that I showed you with the notch. And so the crimson, the Harvard crimson colored dots, represents chimerism from the prostaglandin-derived unit. And what you can see over time is that it's actually the non-treated unit that goes away, and we're left over time with the vast majority of our long-term engrafters engrafting with the unit that we actually treated with prostaglandin. So what we're not doing with this technology is we're not inducing these cells to differentiate beyond stemness, so they retain that capacity to keep growing. And we're actually doing this now in a national randomized trial. It's the PUMA trial. I don't know where they came up with that, but it's 60 patients, and we're treating 1 of 2 units, and maybe one of yours centers is participating. So let's move on from cord and talk a little bit about what's new and what's up and coming in haploidentical transplantation. You've heard mostly about the American way of doing haploidentical transplant, the Hopkins way. And we call it the Hopkins way, rightfully so, because it really was developed at Hopkins. But there are other ways of doing haploidentical transplantation. The Italians probably started doing this before anyone else, and they use a very large conditioning regimen with a big dose of TBI, thiotepa, fludarabine, and then in vivo T-cell depletion. And they give what truly is megadose CD34 cells. There is some theory out there that says if you give so many CD34s, you actually get this veto effect from the T cells. And so they take advantage of this approach. And so this is the Italian approach. They give no post-transplant GVHD prophylaxis, okay? So this is a 3 of 6 transplant or a 4 of 8 transplant, and you're giving absolutely nothing post-transplant. Little ATG before, and then CD34 selection. So you're taking the T cells out of the picture. The group with the largest experience worldwide comes from the Peking Military Hospital, the Beijing approach. And the reason why the Chinese are beating us all at this is because of the policy of single child in China. So there are no sibling donors there, and their unrelated donor registries are less developed. And so it's much more difficult to find unrelated donors in China. And so they pioneered their own approach to haploidentical transplantation. And I heard one of the speakers from this group get up and talk about their last 700 haploidentical transplants that they did at this one hospital. It was, he just blew the room away when he got up there and showed N equals 700. They use again, a big conditioning regimen, so they really are doing myeloablative transplants, Araci, busulfan, cyclophosphamide, mustard agent, and T-cell depletion. They give both bone marrow and peripheral blood, and then post-transplant, they heavily immunosuppress with cyclosporin, mycophenolate, and methotrexate. And the results, if you can believe them, look better than what we get with matched unrelated donor transplant in North America. And then finally, the Hopkins approach, which you've seen before, cyclophosphamide, fludarabine, low-dose TBI, bone marrow, although now there is data using peripheral blood stem cells, which shortens the time to engraft them by a few days, and then triple immunotherapy post-transplant, TAC and MMF, and post-transplant cyclophosphamide, 50 mg per kg. A big whack of cyclophosphamide. Your pharmacists will ask you, do you really mean to give that? So here's the evolving data for using peripheral blood stem cells in haploidentical transplantation. This was a collaborative study from the group at King's College London, as well as the group at the Hutch. What they saw here was an overall incidence of grade 2 graft versus host disease of 50 to 55%. That's actually not higher than their prior reports using bone marrow, where they talk about a 45% rate of acute graft versus host disease, very little severe graft versus host disease, and again, very low non-relapse mortality shown here. And for whatever reason, the rate of relapse when they used peripheral blood stem cells seemed to go down from nearly 50% to the 20-25%. So it's possible that simply switching stem cells here might actually buy you some extra protection against relapse. And then in case you can't decide between umbilical cord blood and haploidentical transplantation, there are a couple of groups out there that have simply said, well, let's do both. And so this is one of these experiences where people are giving both cord blood and haploidentical stem cells to the same patient after whatever conditioning regimen you decide. The rationale for this: the haploidentical stem cells are going to engraft relatively quickly and buy you protection from that long neutropenic period that you see with cord blood transplant. And eventually, 20, 30 days later, the cord blood unit is going to come in and provide you long-term hematopoiesis. Now, we have to think a little bit about costs here, and so you have to buy a cord blood unit, you have to arrange for the harvesting of a haploidentical donor. It probably, from an economics point of view, haploidentical transplant is cheaper a little bit. A cord unit costs you $30,000 to $40,000 before you even bring the patient into the hospital. So this approach, doubles those numbers. You're talking about $50,000 to $60,000 to $70,000 before you even start conditioning your patient. Now, not to be outdone, the group at Memorial Sloan Kettering has decided if one cord blood unit and one haploidentical unit is good, then more must be better. And so Juliet Barker has done double cord transplant plus a haploidentical donor and has shown very similar results. So now you're talking about $100,000 right out of the gate. We have not much time left, but I wanted to talk for the last minute, and if Kath is here, I apologize for going over time, about one thing that applies to both cord blood and haploidentical transplant, the way we search for these units and how this might actually improve outcomes over time. So, I want to introduce the concept of non-inherited maternal antigens and non-inherited paternal antigens. So if this is your patient, you have siblings who are matched or mismatched at different sets of antigens. I'm going to show it here, it's a little bit clearer. So if this is haplotype AB in dad, haplotype CD in mom, this is your patient. Here are the possible combinations among siblings. Obviously, the next combination would be a matched sib. So this person who gets haplotypes BC, you would never use for an AD recipient. But both of these people are haploidentical. This one shares haplotype D, and this one shares haplotype A. This donor shares or is mismatched at the non-inherited paternal allele, NIPA. And this donor is mismatched at the non-inherited maternal allele, or NEMA. Okay? It gets a little more complicated when you start talking about this, the children of this donor, but this applies a little bit less. And the reason why this is important, and for those of you who have the mental fortitude, because I don't, to understand this, I applaud you. Go read the papers by the Dutch group who really came up with this concept. Van Rood is really the guru here. And it turns out that if you can tolerize the recipient to the maternal antigens that they've seen before in utero and they're going to get from a mismatched donor, that might reduce their rates of graft versus host disease. And there's the flip side about increasing rejection and relapse prevention with the paternal antigen. And when people look, almost done, Kath. Oops. When people look, if you simply compare outcomes of maternal and paternal donors, there are very measurable differences in terms of mortality. And again, here with the 4 different combinations, this is using the non-inherited maternal allele mismatch. And so we've now started choosing our haploidentical donors based on this strategy. The same thing applies in cords. So you're going to have a cord unit which is almost always going to be mismatched, but you can choose your mismatches wisely. So if you choose a mismatch at a common HLA allele, say A2, there's a chance that that cord unit was exposed to A2 in the mom, and that cord unit is going to be tolerant to A2. And so if you transplant a cord unit that's going to be tolerant, then you're going to reduce your rates of graft versus host disease. And so the New York Cord Blood Bank now types not only all their cord units, but types the moms as well, and that data is available to you when you're choosing the cord unit. And so you can choose a tolerant cord unit to give to your patient. Not bad, right, Kath? 1 minute overtime. So, cord blood and haploidentical transplants clearly extend transplant to essentially everyone. There are theoretical advantages for both modalities, and this randomized trial that we're doing needs to get done and will suggest a preferable strategy for garden variety transplants. There's improvements to each technology ongoing, and whether the results of that trial will be relevant in 10 years when we finally publish it, unclear, and whether any of these other strategies that I talked about will still be around in 10 years, unclear also. But I think the fields are moving very quickly, and it's very exciting to be part of them. I'm happy to sort of hang out in the back and take questions because I think I've gone over time, but thank you.